Good evening, everybody, and welcome to our webinar from Epilepsy South Africa. I am Sharlene Cassel, your National Director of Epilepsy South Africa, and it's just so wonderful to be here with you this evening. Epilepsy South Africa is the only non-profit organisation in South Africa that focuses only on persons with epilepsy. And tonight we're going to be discussing the contraceptive options for women with epilepsy. We are proud to be an organisation that educates and shares education with as many people in South Africa as possible. So thank you for joining us this evening. We would really like to hear comments and questions on the feed, so please don't hesitate to put those up. I would like to welcome our three doctors that have joined us this evening. To my left is Dr. Judith Carter. So Judith Carter is from Park Lane Clinic. She's a gynecologist, and thank you so much for being with us this evening.
It's an absolute pleasure.
We've got Dr. Jayshree Jeebodh, and she's a fetal maternity specialist, also from Park Lane Clinic, and thank you for joining us this evening.
Thank you for having me.
We've got Dr. Pradeep Rowji, a neurologist who works from Mill Park Hospital with Netcare as well. So thank you, Dr. Rowji, for joining us this evening.
Only a pleasure. Thank you for inviting us.
Great, lovely to have you. So we're going to start this evening with Jayshree just talking us through a presentation as a starting point, and we're going to use from there in terms of our discussion points as our panel this evening. So can I hand over to you, and we look forward to hearing what you have to say. Thank you.
Very much. Okay, so I will be discussing fetal and developmental complications of anti-epileptic drugs. If you could move on to the first slide, please. Globally, 15 million women live with epilepsy that are of childbearing age. It's very difficult to balance the care of a pregnant woman versus the risks of an unborn child. What compounding factors we have to deal with is that there's the impact of the physiological changes of pregnancy. So that means that the levels of the drugs may change in pregnant women, and there's a few reasons for that. And then we also have the concern of the teratogenic effects of the anti-epileptic drugs on the fetus. The next slide shows a very important, I thought this was very important to include right at the beginning of my talk, just to highlight that there's a very critical periconceptual period that we talk about. When you can see by 4 weeks post-conception, most of the important organs, the heart, the CNS, the eyes, the limbs have already been developed. And why I'd like to highlight this is because, especially in an unplanned pregnancy, women may only then discover that she's pregnant at 4 weeks when she misses her first period. But by that time, she has already exposed the fetus unknowingly to the drugs. And quite a bit of development has already occurred. After that period, there's still rapid division of the fetus and growing, and by 8-9 weeks, most of the important organs are already developed. And moving on to the next slide. There's ample evidence to show that untreated epilepsy is not associated with an increased risk of malformations. On the other hand, a fetus of a mom who is on anticonvulsant therapy has an increased risk for congenital malformations. And the next slide then shows what are the factors that are important in influencing teratogenicity. I spoke about timing, that very critical periconceptual period. The type of anti-epileptic drugs, so the older generation, valproate, phenytoin, phenobarbital, associated with a much higher risk compared to the newer generations. The amount of exposure is important as well, so the dosage. And valproate, anything more than a gram or 1,000 milligrams per day is associated with a 2-fold increase in the risk of a congenital abnormality compared to if the dosage was 600 milligrams or less per day. Polytherapy, so being on many drugs at one time, consistently the evidence shows that it increases the risk, at least up to 6 to 8.6% increases the risk of congenital abnormalities. And then genetics plays a huge role. Why do some women who are on anti-epileptics have babies with abnormalities and others don't. So there are other factors that are at play, maybe a genetic predisposition, so a family history of an abnormality. If a woman on an anti-epileptic has a previous child with an abnormality, that increases the risk of having another child, up to about 16% in fact. The issue of folic acid deficiency as well, and there are some of the drugs that deplete they increase the metabolism of folate, so they break it down a lot more, and because there's less folate available, that could also be a risk factor for teratogenicity. The next slide, please. So I thought this table was very important. All the evidence we have so far on anti-epileptic drugs, it has been based on what we call observational studies. For obvious reasons, it's unethical that you can't actually conduct a study. No ethics committee will give us approval for that. So what has been set up is these large registries by some countries, and they include women who have been exposed to anti-epileptics. They look at things like drug dosages. They include them early in the pregnancy before the issue of teratogenicity can even be discussed. I thought what's important on the slide to mention the three important registries: the Europe Agency registry, the North American, and then the UK. Consistently, you can see there that the risk for valproate, and we can discuss this later with my colleagues, is consistently the highest risk for congenital abnormalities. We could look at some of the newer generation like lamotrigine, and that risk is somewhere around 2.9 in the one registry, 1.9 and 2.3. If you look at the background risk for abnormalities in a woman who's not epileptic and not on any anti-epileptics, that's more or less around what the level is in terms of percentages. So the newer generation have a much lower risk of congenital abnormalities. And then moving on to the next slide, please. So this is how I actually approached the topic. There's such an overlap. There are major abnormalities, there's minor abnormalities. Major abnormalities are those that cause surgical, medical, cosmetic, or are of significance. The minor abnormalities are usually just unusual features, facial features in particular. And then there's the whole issue of developmental delays, behavioral and cognitive deficits. And then there's the whole issue of fetal anticonvulsant syndromes, and this actually is where there actually is a structural abnormality, either minor or major, but there's also all the delays, the cognitive, the behavioral delays that go with the syndrome. Just to show you on the next slide, I put a list together. The major organs that are affected is the heart, clefting of orofacial clefting, and then neural tube defects. There are others, although some literature tends to think that maybe musculoskeletal abnormalities is a lot higher, and that we're looking at things like congenital hip dislocation, or small things like a toe that didn't form completely, a hyperplastic toe, or a finger. So this is looking at the digits itself. And then urinary tract abnormalities, particularly things like what we call hydronephrosis, so where there is increased pressure within the kidney and the urine doesn't leave the way it should. And also hypospadia as well in little boys. And then the next slide, put together a list of minor abnormalities. So hypertelorism refers to a situation where the eyes are further apart than what they should be. What's also described is ear and teeth abnormalities, particularly the ears appear as if they're further back and lower. And then the nasal bridge itself is quite flat, which is important from a fetal medicine point of view, and I'll discuss that further. And the nose itself may be short, and I spoke about underdeveloped nails and digits. And then the eye area, we talk about folds, epicanthic folds. And also important is mid-facial hyperplasia, so the middle of the face appears as if it doesn't develop the way the rest of the face develops. And then quite a particular appearance of the upper lip, almost not visible, very thin upper lip, and that little groove that we see between the nose and the upper lip, very, very shallow. And then a downturned mouth, so when you look at the edges of the mouth, they appear downturned, and ptosis of the eyelid, so the eyelid looks very droopy. So if you look at the next slide, I included a picture of a child exposed to valproate throughout the pregnancy, 1,000 milligrams per day. The mother was on folic acid even preconception, and this child was born with very typical features. If you look at the child, I've described if you look at the lateral view, you can see a midfacial hyperplasia, so sort of a smaller, less developed midfacial area, a short nose. And look at the upper lip, very thin upper lip, and that area between the philtrum we described between the nose and the lip as well looks very, very shallow. And then the ears look like they're a lot further back and more low set. So that's the low set ears. On the next slide, please. I've discussed, or I put in a few pictures of the limbs. If you look at the picture first at the top, some of the toes appear like they're deviating or they're angling outward, so we call that more like lateral deviation. But if you look at the baby toe in the first pictures as well, it looks like it almost just didn't develop, so a hyperplasia of the toe. Looking at the bottom picture, looking at the hands, the baby finger looks quite curved, we call that clinodactyly. And looking at the picture next to that, also deviation of the toes. Like I said, very subtle, unusual features. These are minor abnormalities that are described. And then the next slide, please. Okay, so in addition to all the structural abnormalities, I spoke about long-term implications of anti-epileptic drugs, and it has been shown, and the study I have to mention is the NEED study. The NEED study is where they assess the neurodevelopmental effects of anti-epileptic drugs, and they consistently showed, and they looked at monotherapy with 4 drugs in particular. Patients were on carbamazepine, on phenytoin, on lamotrigine, as well as valproate. And they then assessed 309 children over a period, first at age 3, then age 4.5, and then at age 6. And they looked and found, well, what they found was that there was definitely an increased neurodevelopmental disorder incidence across motor, cognitive, and behavioral domains. With valproate, there was a high risk of autism spectrum disorders and attention deficit disorders. They definitely found a lower IQ, particularly the one most common that was related to a lower IQ was the valproate. They also found that the cognitive deficit was most profound. The verbal deficits as well as motor deficits were also very profound with valproate. And what was interesting from the study is that they found that the periconceptual use of folate actually improved the IQ of the babies exposed to all 4 of the anti-epileptic drugs. And then moving on to the next slide. So once again, I spoke about syndrome, and I spoke about the minor abnormalities. I think there's a lot of overlap. Like I said, there are unusual features. We're describing how the eyes look, the nose looks, the ears. Very important from a prenatal diagnosis point of view, we can't diagnose this. So what we may find is that the middle of the face is a bit underdeveloped, but that could be, there could be 100 other genetic syndromes or chromosome abnormalities that may cause it. So what I'm trying to say is that fetal valproate syndrome, or whether it's carbamazepine or phenytoin, are all a diagnosis of exclusion. So once we've looked at all other possible causes, done all possible investigations, and then we'll say, okay, the mom did expose the baby during the critical period, she was on this dose, it's most likely due to this. Most of these features we cannot diagnose before the baby is born. So we're unable to tell you that the lip is thin, or we're unable to tell you, we may be able to tell you the eyes are further apart, but once again, there are many other causes for the eyes being further apart. And then on the next slide. So very important, the woman needs, we would like it in an ideal world for everyone to plan their pregnancy, to then come in, sit down with the doctor, discuss the decisions, what should I be on, what dosage should I be on. Very important for the woman planning to have a child, to be aware of that periconceptual period that is so critical in the development of the fetus. They need to be informed of the risks of abnormalities, what is available in the literature, what we know about the different drugs, and then also that it's not just structural, but there could also be negative or adverse outcome from a neurodevelopmental point of view. And then the very important issue of periconceptual folic acid, and I think most international guidelines, whether we look at the American College for Obstetricians and Gynecologists or the Royal College for Obstetricians and Gynecologists, we recommend that pregnant women or women planning to fall pregnant to actually use high dose folic acid, 5 milligrams, at least 3 months before they conceive and in the first 3 months of pregnancy. And then the next slide. Very important that anyone who is epileptic, or even whether you're on treatment or not, know that it is very, very important to book early. My second slide, where I discussed how rapidly the baby develops, tells you that by the time you get that 4 weeks, quite a bit of development has occurred. We understand there's the unplanned pregnancy, and that patient needs to sit with her doctor and go through a sort of a planning process. What should I do? Should we alter the dose? Should we change the drug? Should we try and decrease from polytherapy to a single drug? The confidential inquiries into maternal deaths has discovered and has suggested that a multidisciplinary team care for such a patient is very important. So not just your attending obstetrician, a neurologist should be part of your team. It should be a team looking after you. And then I think epilepsy, and it's not just me, but it's very important that you understand you are a high-risk pregnancy. We are so, pregnancy and perinatal complications can occur as well, and it's not just the issue of the teratogenicity associated with the drugs, but we know that maternal mortality in women with epilepsy is 10 times higher. So what we're worried about is that there's a high risk for preterm labor, cesarean section, preeclampsia, which is high blood pressure that you can get in pregnancy, and gestational hypertension, which occurs just in pregnancy alone and then resolves once the baby is born. What's important to know, though, is that being on anti-epileptic drugs itself does not increase your risk for an adverse outcome. Okay, and then the next slide. So very important what we do and me as a fetal medicine specialist. We had a previous old model of antenatal care where we very infrequently saw patients in the beginning of the pregnancy, and as the pregnancy progresses, we then saw the patients more frequently. We've inverted that, and we hope that that's what's now being followed as the new model. We want to see the patients more frequently earlier on, so 12 weeks and 20 weeks, and then from there plan the visits accordingly, because we can then stratify that pregnancy into either a high risk or low risk pregnancy. And then on the next slide, we know the first trimester scan that we call this, we in my circle call this the mother of all scans, very important. If there's one scan you would go for in your entire pregnancy, this would be the one to go for. Very specific that it needs to be performed between 11 to 13 weeks, and the baby has to measure from the head, from the crown to the rump. It has to measure 45 to 84 millimeters. If the baby is out of this range, then unfortunately this particular scan cannot be performed. We use this opportunity to screen the baby for chromosomal abnormalities, particularly the 3 common ones, Down syndrome and chromosome abnormalities of chromosome 18 and 13 that we call Edwards and Fetal syndrome. We use this opportunity to screen for major structural defects, and this is particularly important for the woman who has been on anti-epileptic drugs. And then very important for the patient herself, we screen for pregnancy complications. The ones we're concerned about is preeclampsia, which is high blood pressure that occurs in the pregnancy, fetal growth restriction, which refers to a baby that doesn't grow well. And just to also add in that the Royal College guidelines for obstetrician and gynecologists have actually suggested that there is an increased risk for growth problems with some of the drugs, and they recommend serial growth scans for patients on anti-epileptics just to monitor the growth of the baby. And then very important as well, we screen for preterm labor, which I said is also an increased risk in epileptic women, but preterm labor basically refers to a baby born before 9 months, and that's what we can screen, categorize the patient. The aim behind this risk assessment is to prevent. We want to prevent, so we don't need to cure. And then looking at the next slide. So I've put up a picture of what we do, and this is what the view we want to obtain of the baby at that scan. It's the side profile view of the baby. We can see a forehead, the nose, a little chin, and in particular we measure the skin thickness behind the baby's neck. That's called the nuchal translucency. Another name for neck is nuchal. It was originally discovered in the 1980s, and initially we found that the wider it was, the more likely the baby would be born with Down syndrome. And subsequent to that, millions of women had the measurement done, and we realized that it actually detects a lot more for Down syndrome. It's now become one of the most important screening tests for heart defects, which I did say that's one of the major defects that occurs in women who are using anti-epileptic drugs. So screening for heart defects with the nuchal translucency is actually very critical. And then the next slide. Very important when the patient comes in that they understand that there are limitations. Like I said earlier, we cannot diagnose everything. So what can we see in the first trimester? I spoke about neural tube defects, and that refers to defects of the neural tube where it doesn't close properly. And the three common ones are anencephaly, where the actual bone that covers the baby's head doesn't develop, encephalocele, which is a defect in the bone itself, and spina bifida, which is an abnormality on the spine itself. The neural tube closes very early, by day 26, before a woman may even miss her first menses or menses and realize that she's pregnant. And if it doesn't close, that is when we get the defect in the spine. Very important, if you think coming in at the 12-week scan, we're then going to be able to tell you the spine is normal or not. It's not. In the best of hands, direct visualization of the spine, we can detect somewhere between 30 to 60% of spine abnormalities and not more than that. We do rely on looking at the brain to tell us if there could be a defect in the spine, because when there's an abnormality in the spine, it affects the brain. That is really the pathology of the disorder. And then the next slide, please. So can we tell you about the baby's lip and palate at 12 weeks? No, we can't, unfortunately. It's not possible for us to see the lip. It's not possible for us to see the palate. They do develop quite early. The lip develops between week 4 to 7. The palate develops between week 6 to 9. They can be on one side, so unilateral, most of them are, but they can be bilateral, so there can be two of them on either side, and they can be a median cleft, which is the complete center portion of the lip that's not present. Very important to remember that the roof of the mouth, which is what we call the palate, has an anterior front portion that's made of bone. Bone we can see with ultrasound, and we can tell you at 20 weeks whether there is a cleft or not in the palate. We cannot see the soft tissue which forms the posterior aspect of the roof of the mouth. So we are unable to diagnose soft tissue defects. Very important, cleft lip and palate is associated with hundreds of genetic syndromes and other chromosome abnormalities. So it really does become a diagnosis of exclusion once we've excluded all other possible causes. And then on the next slide, I've included a bit about the heart. So if you come in and think, are you going to be able to tell me that my baby's heart is normal or not? I've included pictures of the baby's heart that I've taken at 12 weeks. It's a small organ, millimeter small. Like I said, we would do the nuchal translucency. We would measure the blood flow to the heart, and that would help us to decide if there could be a defect. We may be able to pick up a very severe defect of the so-called 4 chambers of the heart, but the blood vessels leaving the heart, we may not be able to see clearly. If we are suspicious, most people may ask you for an additional visit at 16 weeks, so we can then start to assess the heart in greater detail. Very important, we need to know whether the defect is severe or not. What happens is, as the pregnant woman starts to feel movements, she bonds with the baby, and to get told at, say, 22 weeks there's a problem with the baby becomes very traumatic for the patient. So the sooner we can, the aim is to push the boundaries and to try and diagnose as early as possible. And then with the next slide. This is critical for the woman who has been on anti-epileptic drugs. We do a detailed anatomical survey of the baby. Once again, we screen for chromosome abnormalities. We reevaluate for pregnancy complications, the high blood pressure I spoke about, the preterm labor, the possible growth problems. We plot all the growth parameters and graphs. We work out blood flows from the baby, from the uterus to the baby, and from the mom to the uterus. And then, once again, I'd like to highlight in terms of features for the syndromes, very difficult because there is so much of overlap, and the features are so subtle, and they can actually overlap with many other conditions. And then the next slide. So I spoke about abnormalities of the spine, which we call a spina bifida. It is an opening in the spine that affects the brain. Some doctors may do a blood test for you around 16, 18 weeks, where they measure an alpha fetoprotein level. That will pick up about 3 out of 4 babies with an open spina bifida. In other words, about 75%. But the gold standard for diagnosis is to actually look at the spine at the 18 to 23 week scan. In good hands, the diagnostic accuracy is up to 98%, but we're more likely to quote that we would detect somewhere around 80 to 90% of spina bifida. We rely very much on looking at the brain, because the brain gets affected with the spine that is open. The entire brain gets pulled back. And there's a change in the shape of the head. I've included as well a 3D image. This is the one time when 3D is of value in fetal medicine. And what I've done is I've looked at the spine. It gives us a very, very clear view of the bony structures of the spine. And all women who are on anti-epileptic drugs should get a 3D view of the spine at this gestation. And then the next slide, please. Okay, the heart. This is the best time now at 18 to 23 weeks to detect the heart. Once again, we cannot detect 100% of heart problems. It's just not possible. Most of what the heart is busy growing, but most of the work's actually done by the mom and the placenta. When the baby's born and starts to work is when the other 10% of severe abnormalities may then present. The heart develops quite early, like I said, from week 3. I would advise that anyone on an anti-epileptic drug have, in addition to the scan by your fetal medicine specialist, a detailed fetal echocardiogram by a pediatric cardiologist, who then spends time looking at more details in the heart, and they are able to diagnose a lot more because that's their area of speciality. I've put in a bit on prognosis. At the end of the day, it depends on what the abnormality is. The more severe the abnormality, if we know long-term outcomes are not good, the prognosis is then worse. Some abnormalities, and perhaps most of them, can be repaired, and the prognosis would be better for those. And then the next slide, please. We encourage breastfeeding. Breast milk is the best for the baby. We do know that most of the anti-epileptics are secreted in breast milk. Should the baby be a bit sleepy, a bit tired, you may just have to time when the anti-epileptics are taken. So you may just have to take them after the feed, just to try and avoid the peak in the serum and the breast milk. Lamotrigine is excreted or secreted in the highest amount in the breast milk, and it's one drug that should not be initiated in breastfeeding moms. On the next slide, please, I've put in a list of the drugs and basically what the percentage is of the drug that appears in the breast milk, and that's proportion of the blood levels in the mom. And as you can see, the least is actually valproate, less than 10%. Lamotrigine about 61%. And then the next slide, please. My last slide. Epilepsy is not a contraindication to pregnancy, and good news is that over 90% will have good outcomes. It is critical to be aware of that periconceptual period when and one should be counseled before you fall pregnant, so you are aware of it. And the aim is to actually intervene early and minimize the risks of complications. Thank you.
Thank you, Jayshree. Wow, lots and lots for us to think about. Jayshree, I think that the question that has certainly come up is, what is the folic acid? You mentioned that it's really critical pre-pregnancy and during pregnancy for a woman with epilepsy to be on high doses of folic acid. Can you just explain really basically what folic acid is?
So folic acid is a vitamin. We find it in our leafy green vegetables. Unfortunately, most of us don't have enough of it. Most governments have fortified cereals, and in our country it's maize and wheat that's fortified to try and increase the consumption of folic acid. But we don't get enough of it. Multivitamins have it. They have about 400 micrograms, but it's not enough to prevent the neural tube defect. It isn't enough, that abnormality of the spine. So that is why we recommend a much higher dose. Very easy to buy, over the counter, really not expensive. And they come in 5 milligram tablets. And that's what you would take any time of the day. It doesn't have to be taken with meals or anything. But if anyone is planning a pregnancy, I would suggest they start with it. I always tell my women who have childbearing age, because so many pregnancies are unplanned, I say take folic acid until you reach menopause, because we never know. At least you've been on it, and it then helps to prevent the or decrease the risk of neural tube defects. In someone who has had a neural tube defect, we do know that using the folic acid halves the risk, so it decreases it by 50%.
Okay, thank you so much. What I would like to ask Judith is just if you can talk to us a bit about what are the options we in terms of women with epilepsy, what are the options to look at? So we've heard that folic acid really makes a significant impact. We've heard so much information, and thank you. It's really triggered a lot of thought, I think, and a lot of, in all of us, I'm sitting here going, okay, tick, tick, tick. Can I hand over to you just to chat through some more of the information that we're hearing?
Okay, so,
thanks, Judith.
I mean, it's a very complicated subject, to be honest, talking about contraception in epileptic patients. And there's not that much data on it, unfortunately. Excuse me. So if we look at the different options that we've got the oral contraceptive pills, we've got injectable contraceptives, we've got an implant that you can put in your arm, and you've got devices that you can put in your uterus called intrauterine devices. Now, when we look at contraceptive pills, we can probably include in that patches. So there's contraceptive patches, there's a vaginal ring that you can put in every 3 weeks. And these are very commonly used contraceptives, but these are probably the contraceptives that are going to be the biggest issue for an epileptic patient. Because a lot of the old-fashioned epileptic drugs actually increase the metabolism of those hormonal contraceptives. So in other words, your body chews them up, and it means that you don't have a high enough dosage of hormone in your circulation to stop you from ovulating and to keep the lining of the uterus thin, which is how what we call the combined hormonal contraceptives work. So back in the day, we were told, well, if you have an epileptic patient who needs to be on the pill, well, you can give her a very high dose pill. So there was a very high dose pill called a 50 microgram ethinyl estradiol pill at a point that was actually quite widely used in the 60s and 70s, but we really don't use it very much anymore. So now, because we can't really get that so easily, we would tell women to use 2 other pills in conjunction and take those together. So they're basically taking 2 contraceptive pills a day, whereas everybody else is just taking 1 contraceptive pill a day. But the problem with that is it's a complete thumbsuck. We don't know for sure that taking that high dose of estrogen means that once the drug has passed through the liver and is now in the circulation to suppress ovulation, whether it is enough, whether it is too much. So it's a little bit of a hit and miss using an oral contraceptive in that way. So we often try and shy away from the oral contraceptive for that reason, because a lot of women won't know these issues around the usage of combined hormonal contraception and how it's affected by the drugs that they may take, particularly the more old-fashioned drugs, which are often going to be the drugs that are more used in more rural areas where there perhaps isn't such good access to the newer drugs that we have available. So that's the one aspect that's important. But the other aspect that's important is, for example, if you look at a drug like lamotrigine or valproic acid, you can actually affect the dosage or the amount of those drugs within that person's circulation by taking a combined hormonal contraceptive like a pill. So what that means is that now this person is not getting adequate drug in her circulation to suppress her seizures. So she may now actually end up having seizures because she has been put onto a pill, for example. So we've got to be mindful that it's not just the fact that these drugs can affect the contraceptive function, it can be the other way as well. Okay, so a lot of the newer drugs are not enzyme inducers. So in other words, they don't chew up the contraceptive as rapidly as the older fashioned drugs. And so one of the ways that you can counteract this issue is if there is a patient who really, really wants to use the pill because she's got terrible acne or a hairy face because of polycystic ovarian syndrome, you may actually have to speak to the doctor looking after her to find out, is there not a way we can put her onto a drug that does not, that doesn't affect the pill's functioning as much. So one of the non-enzyme inducers, one of the newer drugs. Okay. But let's look at what the other options are. So the injectable contraceptives also can be affected by these enzyme-inducing anti-epileptics, as can the implant. So in our practice, we often very much steer patients towards intrauterine devices, of which probably the copper intrauterine device is going to be the absolute safest because the copper is not affected in any way by the drug. And then you have what we call the levonorgestrel intrauterine systems, which are very commonly used by patients these days. And there's not a hell of a lot of data on it, but we think that those, certainly the higher dose levonorgestrel intrauterine device is perfect for a patient with epilepsy and on these kinds of drugs. So many, many women will find themselves on one of those intrauterine devices. It also minimizes the number of medicines they have to take every day, which I think is very important because it's a burden to have to take a handful of pills every day.
I think, Judith, you're so right. You know, as a woman with epilepsy myself, I think one of the things you don't want to do is continually add to all that regimen of drugs. So adding another one to prevent your pregnancy or to use as a contraceptive option, which we know is, it does tend to, and I'm sure Pradeep as a neurologist on our team tonight would discuss that as well. And you have that psychological side of a woman going, oh, not another tablet, not another, particularly. And the other concern is, what sort of access do women in our outlying areas have to contraceptive devices that aren't oral? And I think that becomes a whole another discussion. So, Pradeep, would you like to add to what Judith is saying in terms of
I have a question, in fact, Judith. The question I have to ask is that, you know, a lot of our patients in the rural areas, and in particular in low-income areas, go to their local clinics. And generally speaking, they would only have access to the injectables.
Yep.
So speak to us more about the injectables and what your thoughts are with regards to that.
So that's very, very interesting, and that's exactly what I was alluding to earlier. Patients who don't have the kind of access that we may have in Johannesburg to all of the different kinds of contraceptives and even all of the different kinds of anti-epileptic drugs are going to have a little bit more of a struggle. So if you look at something like the injectable contraceptive, which is very, very popular in our country, particularly in the underprivileged areas, there's two issues associated with it. Firstly, the enzyme-inducing anti-epileptic drugs can certainly affect the functioning of the injectable contraceptive, and that needs to be borne in mind. But not only that, some of the anti-epileptic drugs are associated with the development of osteoporosis, and we know that an injectable contraceptive, certainly if given in the late teenage years or in women in their 40s, also compounds the risk of osteoporosis. So we've always got to be very careful that we are not augmenting that osteoporotic risk by choosing a contraceptive that is going to accentuate that effect. So it's a real problem. So for those sorts of patients, education is key, and that's I think why a talk like this is so very, very important, because they need to understand that if this is what is available to them, they realize that perhaps it's not the best option that they can access, but it's the only option that they can access, then they must use dual contraception. They must add a condom as well. And by using a condom as well, you are creating then a far more favourable contraceptive setup, where her chances of conceiving are going to be much lower. The copper loop is pretty widely available, and I think that would also be a good option. But the problem is it is not necessarily that easy to insert, and community nurses perhaps don't have that skill, which is a pity. And that's why perhaps these patients will be given Depo-Provera. I think if they use Depo, it's fine, but they really should use condoms as well. And it's important for them to understand the risks that are associated with falling pregnant on these enzyme-inducing anti-epileptic agents.
Thank you. I think it's to understand those risks, what Jayshree has really expounded on, is it makes it even more, I don't know, I suppose the word is the necessity of education is even more, that we really know. And one of the things that you mentioned was having a team as a person with epilepsy from the word get-go being involved, because a multi-tier approach of having a neurologist, a gynae, and a specialist, a fetal specialist, whatever it is, to inform. And one of the things that as Epilepsy South Africa, our mission is to educate as many people with epilepsy about it and give them as much information. So absolutely agree with you. That's why we're here tonight, is to share that information and say, use this information wisely, take it and apply it. So I think maybe, Pradeep, you're looking like you're going to jump in, so please do.
No, so just going on to, in terms of my approach and how I approach my patients at the clinic or bedside level, is that I would always recommend immediately on the patient informing me that that she is or they are now pregnant, is to obviously ensure that they get a screening by obstetrician gynecologist. And then I didn't know that Jayshree was a fetal specialist. Now that we do know, she's going to get inundated from the practice that I have of the number of patients that we have. But I think it's vital, as she's pointed out, it's vital to have that team approach, because that is key to ensuring safety for the mother, but more than that, for the child. Because this is what we're talking about, right? We're talking about the unborn child. And as we understand, every mother has this amazing expectation of their child. And we need to inform them about the risks of each of the drugs, the risks both while they're pregnant and afterwards, because there's the risk of breastfeeding, not just during the pregnancy and the use of anti-epileptics, but it's also about breastfeeding. And thereafter, when they're little kids, that they might have children with delayed cognitive skills and behavioral changes. And all of those factors need to be, informed to the parents. And so I think it's important that the team works very closely. And I think that is something that I'm sure there's a huge gap in our private sector. And can you just imagine what it's like in the public sector? It must be a massive gaping hole, probably bigger than the size of the Kimberley hole that we know about. So I think it's vital that this sort of information goes out, and that this message is spread, and that women in particular have to be empowered about their choice of contraceptive. And there are many choices, as Dr. Judith has talked about. And I think we need to spread that information more widely.
If I could also just make the comment that if you look at the data, about 50% of pregnancies in epileptics are unplanned.
Wow.
Okay, which is very similar to the baseline rate for just your regular patient on the street. So what that means is that epileptics actually don't realize that they need to plan a pregnancy.
Sure.
And that if they are not ready for a baby, that they need to have adequate contraception in place. And they need to understand that that is not, it's actually seldom, the oral contraceptive pill. The problem also comes in with the fact that it is not just the general public and epileptics who don't have this information. Yeah. It's the doctors or the healthcare professionals treating them, all the way from the community nurse through to, unfortunately, some gynecologists even. So it's very, very important that we get that word out there from everybody, right down to the man on the street in general, to the person with the epilepsy, to the nurses, the GPs, etc., because there is a lot of misconception, or people think that everything applies to them as it does to the person without epilepsy who's not on these medications, and it isn't the case at all.
Sure. So I suppose the question that's coming to mind as I'm listening to you is, if you're saying 50% of women with epilepsy, you've just shared with us, fall pregnant unplanned, will have an unplanned pregnancy, they're then really putting themselves at risk, because they're at risk if the contraceptives, the oral contraceptives, are already cancelling their medication out. So what happens when the hormones shoot up and they are pregnant? What are in terms of that space of conceiving, and maybe it's for you, Jayshree, is that what is the conversations that should be happening at that stage where a woman has fallen pregnant by accident? Where does she go for information? Where does she, particularly in our areas where it's only government hospitals, there aren't specialists involved? How do we give a woman in that space, the support she needs?
It's a difficult question. I don't know if I would be able to answer that. We do know, I can tell you that the tertiary hospitals in the big centres do offer a fetal medicine service. Okay. And I know, having worked at Baragwanath Hospital for 18 years, that a 12-week scan is a walk-in service. Okay. So if the patient comes in and she's 12 weeks in one day, she would get the ultrasound immediately. The uptake is poor, and only about 20% of the scans performed end up being first trimester scans. So patients aren't aware. The key is education, education, education. So they don't book early enough. So what happens in a typical setting, government setting, is patients book much later. And they've missed the 12-week and they've missed the 20-week assessment by the time they book. So I think it's about educating women, and it's about educating the healthcare practitioners, the people looking after. So it means it's the midwife who needs to say, you need to book early, and then from there, let me refer you. So you have to have, and what happens in all other countries, it's patients book first with midwives, and then they get referrals to the GP, and then from the GP to the specialist, and we don't have that kind of system in place, so it doesn't function that well.
Yeah.
That's a problem. So we hope that education is the way to actually.
So one of the other things that the neurologists do as a general rule is that when we initiate an anti-epileptic, we also initiate folic acid.
Okay.
So once a diagnosis is made, confirmed, and we're ready to start an anti-epileptic, we start that patient, especially women of childbearing age, on folic acid. Okay. Because we know that most, if not all, of the anti-epileptics, when they get metabolized in the liver, use up the folic acid pathway. So folic acid is going to get metabolized. And then you're going to get folate deficiency, in which case you're going to land up with the fetal abnormalities. So as a general rule, I mean, I know it for a fact that once we heard that was a preventative agent, we used it in every patient. It wasn't something that we excluded. And I think that message should go to all doctors, all healthcare providers. And if there's a sangoma looking after a patient, should also know that folic acid can be used in that particular setting, but it's vital. So we actually put it on the script for every patient. Once we initiate an anti-epileptic, every patient gets folic acid.
And thank you, Pradeep. And how do we share, like when a neurologist puts a patient on, a woman of childbearing age, on anti-epileptic drugs, is the neurology and sector, the neurologists of South Africa, or even globally, are they having that conversation? Are they equipped right up front to be saying, you are a woman of child, you are a person with epilepsy, and these are your risks with your AEDs that you're on? And are those conversations happening, and how do we make it more so? How do more people come to the table?
Well, I think, as we say, I think the message should be, as soon as any healthcare provider starts an anti-epileptic, whatever the anti-epileptic is, they should actually start folic acid, because that female patient, as we've discussed, 50% of them are going to have an unplanned pregnancy. So we need to be aware that is the risk. If 50% of females are going to get impregnated and would not know, and in that first 4 weeks, the critical 4 weeks, when you don't even realize you're pregnant, you don't realize you've missed your cycle, you're going to be having a fetus that's already exposed to the anti-epileptic. So the the patient has access to the preventative agents like folic acid, the greater the risk is mitigated. So I think it's vital that should be, you know, the standard rule, that as soon as an anti-epileptic is started, it makes no difference whether it's valproate or lamotrigine or any of the agents, there must be folic acid added to the concoction.
And Pradeep, just a question that's coming up now is, when a woman is on an anti-epileptic and she falls pregnant, are there symptoms that she could be looking for regarding her seizures that are breaking through, more petit mals, more grand mals, sleeplessness, heightened anxiety, depression? What's that woman, what can she be looking for as signs of maybe a warning of having been pregnant? Is there something a woman can be looking for?
Ladies, I'm gonna turn this one on you, because I have absolutely no idea what I'd be.
By the time when you've missed your period, for most patients, they'll be lucky to have tender nipples and feel a little bit tired. I mean, the nausea only comes at around 6 weeks, 5.5 to 6 weeks. So you've missed the boat, unfortunately. And that's why this is such an important discussion. Just as an aside as well, I think it's very important to mention that we've given people a lot of information today, but what we haven't imparted perhaps is that epilepsy is a very serious illness, and if it is not controlled adequately in a pregnancy, and you have a woman who is seizing, that can have tremendous negative effects, not just for her, it can be life-threatening for her, but it can also have tremendous negative effects on the baby as well. And a lot of women will look at the information that we've discussed here around what can happen when you're on an anti-epileptic drug and now you fall pregnant, and think, but I'm not going to take that medicine. I'm going to protect my unborn baby. Now, I don't want to be on a medicine that's going to affect my baby. And yes, we as healthcare practitioners hear that. But what they need to understand is that sometimes the result of not being on the medication is worse than the actual medication. So saying I'm not going to take my drugs because I don't want to expose my baby to these potential risks is not the answer. And if there's one thing that the lay public out there who are listening to this must take home, is that please, you can't just stop your anti-epileptic agents. It's better to get advice from people to help you, guide you through that. Don't stop your medicine. Seek advice so that we can try and help you navigate the situation. But we can't help you if you end up in what we call status epilepticus, and you can lose your life and you will lose the pregnancy as well.
So what do you advise for a woman of childbearing age, Judith, in terms of contraceptive? Would you say absolutely, you've mentioned I think it's the copper T.
The intrauterine device.
So is that the guidance? Is that, and what is the percentage to falling pregnant? What is the, you use certain different contraceptive solutions, and some of them have higher pregnancy prevention rates than others. So maybe we could just talk about that, because you've mentioned that the anti-epileptics will really be, the efficacy will be dropped because of the pill, for example, or maybe it's the patch or whatever it is. So can you just talk to us a bit about those things?
Right. So firstly, I think it's important to understand that it's mostly an effect of the anti-epileptic affecting the contraceptive. It's just a couple of agents where the reverse is true, specifically lamotrigine and valproate, I think, right? So it's mostly the fact that if you get put onto this hormonal contraceptive, your contraceptive might actually not work, right?
So I'll give you a simple one. Sorry, Dr. Carter. So a simple thing is, everything we eat goes through into our tummy. From the tummy, it has to go through to the liver for processing. Once it is processed, it then gets distributed to the various compartments of the body, and it does what it has to do. The problem with all anti-epileptic drugs is that, like every other medication or any other food item for that matter, has to go through the same pathway. Some of them actually induce enzymes, so they become more effective at destroying that anti-epileptic. So what we generally tend to do is we'll monitor drug level, And if the drug levels start dropping, because some of them are enzyme inducing, we increase the dose of the anti-epileptic.
Okay.
But the problem is that while it's doing that to the anti-epileptic drug, it can do the same to the oral contraceptive drug, the oral contraceptive agent. So what happens is if I give you, or the female gets given a year's tablets, which is a real mild contraceptive,
Yeah.
you may find that it has no benefit at all, and the patient might still get pregnant. So that's why they talk about doubling up the dose or finding a higher concentration of the the oral contraceptive pill to kind of mitigate against that. And vice versa, some of the oral contraceptives can actually lower the anti-epileptic medication. So once we start the patient on an oral contraceptive pill, we find that the levels of the anti-epileptics drop, in which case we then have to bump it up.
Okay.
The other problem is also during pregnancy, there's a whole new physiological change that's happening to that mother.
Sure.
And during that period, some of these anti-epileptics get bound to protein. And when the protein concentrations may change in the pregnancy, we find that the levels may drop or sometimes become a little too high. And so we've got to have a team approach. We're monitoring the anti-epileptics and ensuring that the mother's within range. And as Dr. Carter has mentioned, we can't afford to have a mother have a seizure in their pregnancy.
Yeah.
The risk is far too high to the mother, but most importantly to the unborn baby. And we can't afford that. So I think it's vital to send that message out that you should not stop yourself from using an anti-epileptic in the setting of a pregnancy because there might be a risk. Because that risk is really low. And Dr. Jeebodh mentioned very clearly, 90% of mothers will go through their pregnancy without any issues. I think it's even higher than 90%.
Okay.
So it's vital to understand that you should not stop your anti-epileptics. You have to have a team approach in terms of the anti-epileptic management, in terms of controlling the levels during that pregnancy and monitoring it, but at the same time monitoring the fetus and managing the issues as they may arise related to the use of the anti-epileptic. Okay. So that's the importance of that balance that we have to strike to ensure safety through the pregnancy.
And thank you, Dr. Rowji. I think what's coming up so clearly is that even as a person with epilepsy without being pregnant, that balancing act of getting the levels correct when to keep the epilepsy under control is also, it's a whole another bag of problems or challenges that we're seeing because every woman's system and body is so different. So we go back to the genetics that you mentioned. We've got a couple of questions about folic acid. It's really eliciting on our chat room a lot of conversation about, is it a contraceptive? Does it prevent pregnancy? We've got another one that somebody is answering that. And, you know, there was another one when I was finally put on folic acid. I was shocked that that the neurologist advised me that since I'd taken for a prolonged period, that folic acid there wouldn't be any side effects for the future fetus. So maybe let's talk a bit more about folic acid. There seems to have elicited quite a large conversation, Dr. Jeebodh.
What would you like to know about it? It's definitely not a contraceptive. It's a vitamin, as I said. So,
yeah.
And then it cannot prevent 100% of abnormalities. It would decrease the risk of it. I spoke to you about it improving IQ. So we know that from the multi-center perspective observational study that was done. But it cannot prevent 100%. But decreased is better than none, in my opinion.
So if you have to be on an agent to suppress your epileptic seizures, you can't not be on that medication.
Okay.
So you take folic acid in order to mitigate the risk to the fetus from that anti-epileptic medication. Okay. So, you know, as Jayshree is saying, you cannot take that risk away completely. I mean, in the normal population, there is a baseline risk of spina bifida. Okay. Folic acid will take that risk down from what it would be relatively high in the woman on an anti-epileptic drug and not on folic acid, probably not quite to baseline, I would imagine, but maybe just slightly higher or even if it's just a little, if it's fairly substantially higher than baseline, that has to be better than what it would have been if the woman hadn't received folic acid.
And even if someone's had a child with a spina bifida, the recurrence risk is about 8 to 10%, and taking folic acid takes it down to about 4 to 5%. So even then, the risk doesn't go down to zero.
Yeah.
Okay.
I also want to mention I have 2 little girls who barely ever eat green leafy vegetables. So I don't know what the baseline rate of folic acid deficiency is in our teenage young girls, you know. So I think that's also another factor, I'm sure, that probably contributes. So if you're already starting on a net loss of folic acid in your system, then that replenishment is vital. So I think it just, for me, it's a rule of thumb. I would add folic acid. And I don't, and you know, so the patients always ask, but doctor, what do I need that second drug for? And I want to remind you, it's not a drug, it's just a vitamin, nothing more. It's a vitamin, an essential vitamin in the setting of a woman of childbearing age, but much more essential when you have epilepsy, because we need that folic acid as a preventative. So that's all we're adding that folic acid for, but it's important. If you're not going to take the folic acid and it's a little too expensive, which it's not, then have lots and lots of green leafy vegetables.
And that opens up a whole nother can of worms right there.
Absolutely.
About access to food, like we're seeing with COVID in the last almost 2 years, where we've just seen our landscape change so drastically. I think one of the questions that, so does the levels of folic acid then get affected by an oral contraceptive? So, or does that become just redundant because it's?
No, I don't know that it has any role whatsoever. Okay. Folic acid oral contraceptive pill.
No.
Probably unrelated. It's the anti-epileptics and the pathway by which your liver metabolizes the anti-epileptics, which requires the folic acid in that pathway. It's a methylfolate pathway, and it requires folic acid as the agent.
Okay. Dr.
Just to go back to talking about contraception and what is the best option for a patient who's epileptic. So if you have a look at the effectiveness or the efficacy of contraceptives in general, for anybody, the intrauterine devices far exceed taking an oral contraceptive or using a patch or a ring. So we talk about perfect use of a contraceptive, and we talk about typical use of a contraceptive. Okay. So what's beautiful about an intrauterine device is that perfect use and typical use are the same. Okay. Because when you put it in, it's there and it works. Yeah? Whereas if you're putting a woman on an oral contraceptive pill, if she takes it perfectly, contraceptive effect is fantastic as long as she's not on an enzyme-inducing anti-epileptic. But what is the typical way most women take the pill? Well, you know, as a matter of fact, in teenagers, they probably miss 2 to 3 pills a pack. Okay? They forget that certain antibiotics can affect the functioning of the pill. They went to the seafood restaurant, not so much anymore, last night, had horrendous diarrhea. That pill went straight through into the toilet. That is typical use of the pill. And as a matter of fact, that makes the pill far less effective than an intrauterine device. And the thing about the intrauterine device is that it's working locally. It's working in the uterus. Even the copper IUD, it's working in the uterus. The hormonal IUDs, you may have some detectable hormone levels for the first 3 months, but mostly working within the uterus. And that is why they are so much better for women on these sorts of medications. Yeah. And that's the problem. The implant, which is also a great contraceptive, you put it in, it stays there for 3 years. But the problem with it is it's a lot of hormone in your circulation. Okay. And whereas it's not working locally. And that's why it can be affected by this enzyme induction problem that happens in the liver. And that's why there's no doubt that the intrauterine devices are best. However, there are categories of patients in whom you are forced to use an oral contraceptive, for example. Okay. Because they have got terrible polycystic ovarian syndrome, they need the medicine to help the acne, to help the hairiness. But in those sorts of patients, you either are going to have to give them 2 contraceptive pills to take a day, or they have to religiously take that one contraceptive pill and use a condom.
Yeah.
Okay, and the other thing, for example, with a drug like lamotrigine, where the pill actually affects the amount of lamotrigine in your circulation, those sorts of patients, when they commence the pill, need to have the dosage of lamotrigine adjusted to make up for the fact that now the pill is dropping the amount of lamotrigine in your blood, and then they need to skip the placebos. Okay, because if they don't do that, then every month they're going to at certain times of the month have too little lamotrigine, and then at other times of the month potentially too much. You understand?
Yeah.
So it gets very complicated, and that's why we try to steer away from the oral contraceptives. But if a woman has to use an oral contraceptive, there are little tricks that we can use to try and make it work for her and make it not too difficult on the neurologist with constantly having to go up and down and, heaven forbid, having breakthrough seizures. But you don't want to risk that, you see.
Can I just ask Judith, to each of you, we've got a lot of names of various epileptic drugs. Can we just talk to the man in the street's names? So we know that Lamictal becomes Epitech. We know, can we just discuss that to share and inform our audience in terms of what their understanding contains those elements and what drugs are actually that? Can we, I know there's a lot, you mentioned prior to us coming on how many drugs are available for epilepsy, and we're aware of that, but there's certain drugs that are used in the government system as a blanket. So can we just unpack that a bit?
So let's talk about the dangerous ones that are much more dangerous than the others.
Yeah.
Versus the ones that have always been used and safely used and are considered the safe drugs during pregnancy. So let me start with the monsters first. There are quite a few of them.
Okay.
So the first drug that we've always had and have used and still use today is phenobarbital.
Okay.
Really very, very potentially toxic, not just for the fetus, but for the mother. So long-term use of phenobarbital is associated with a whole range of things, but in particular bone health. And we talked about bone health in women, and we can't afford to forget that. And it's vital that they don't just get osteoporosis. They get thinning of the bone, and they get other forms of issues that may develop later on in life. So phenobarbital, oldest drug, real nasty, but when we need it, it really works well, and especially in the setting of refractory epilepsy, we still use it.
Okay.
Then came phenytoin, which is also an older drug, also an amazing drug, but also a gremlin with lots of side effects. Bone health being another one of the big no-nos in terms of phenytoin with women in particular.
It would be epineutin, right?
Epineutin, the all-day epineutin, yes. So, and the other name for phenobarbital, besides the phenobarbital as we know it, is it comes in one standard package, and it's called lethal. And it is exactly that. For that particular reason, it's a lethal drug, and it really works well. But that's the trade name. Phenytoin or epineutin is the other name for phenytoin, and phenytoin sodium is the other way to look at it. It was an amazing drug, and we use it for years and years and years. The other advantage is that we can give it to you intravenously, so if you come in with seizures, we can break a seizure very quickly and stop you from going into status epilepticus. Then came the new kid on the block, that was valproic acid, and that was a game changer for us. It is still today one of the best anti-epileptics to date.
Okay.
And no anti-epileptic has ever shown the efficacy that valproic and valproic acid.
Epilum.
That's Epilum.
Epilum other than
So there's Epilum, there's a generic called Epilazine, there's a generic that's called Navalpro, and then there's a variety of it, sort of valproic acid, there's sodium valproate, and that's Convilax is the other one. So there's 4 agents that one can use there.
Okay.
And that's probably the worst one for pregnancy.
But in terms of the fetus, that's probably the worst, and in fact that's where the greatest data comes. The advantage is that it can be used for a variety of seizure types. So I just want to come to that in a second. And then comes topiramate, which is also another very, very toxic drug for the fetus. So those 4 are the big gremlins in our working classifications of drugs for women of childbearing age. And we try to limit that, not just in terms of usage, but also in terms of the dosage that we would use. If the woman's pregnant and we know that the patient has a need for example, or for Epilum, we want to reduce the concentration of that and maybe add a drug that won't have as much of a side effect. But again, then we're faced with the other problems that when we're adding 2 or 3 drugs, there's a higher rate of teratogenicity associated with the use of polypharmacy. So ideally we want monotherapy. Then we come to the ones that have always shown to be really beneficial in pregnancy, and the oldest of them is carbamazepine. And carbamazepine has proven to us that it almost matches the baseline rate for fetal abnormalities.
So what's its
Tegretol.
layman term?
So
Tegretol.
that's
Coming to Tegretol.
Old drug, Tegretol.
Problem is that Tegretol had lots of generics, and a lot of those generics didn't work as well. So what would happen is that the patient would be swapped to a generic, and in fact, one of the things that we dislike about generics is because of carbamazepine. So the first sort of carbamazepine generics, Degranol was the one of classic one, was one of the worst generics that ever was made in the world. And every time we converted the patient from Tegretol to Degranol, they would develop recurrence of seizures. So it was one of the worst generic that was ever created, and it really put us as neurologists off the use of generics. Having said that, things have changed, and now we have much better generics and more compatible generics to the originator. And then there's the lamotrigine, which also comes in at about the same rate in terms of fetal abnormalities as the carbamazepine. And again, one of the better drugs out there, commonly used in psychiatry, very frequently used in psychiatry. And you know, if this conversation was to be had as women of childbearing age with epilepsy or women of childbearing age with a mood disorder, it would be the same thing, because Epitech has been shown, or Epitech, which is a generic of lamotrigine, and lamotrigine in particular has been shown to be a phenomenal mood stabilizing agent.
Okay.
And in fact, it was a South African psychiatrist who's been practicing in America who actually published that particular bit of data, 2 South African actually, who have published that data years back. And they've shown that anti-epileptics actually have a wonderful role in mood stabilization in patients with mood disorders, whether you have a generalized anxiety disorder or bipolar mood disorder or just a pure depression. They actually help towards improvement of the mood disorder, and then the psychiatrist doesn't use as many drugs to control their mood disorder. And that's why they get used as much. So if you look at, of all the drugs that are out there, lamotrigine is the most commonly prescribed drug for mood disorders as a mood stabilizer.
Yeah.
And because of that, there are so many generics as well, because it's such a good drug, right? So everybody's thrown in a generic. And there you'll find at least 10 generics available, if not more. I may be wrong if I say to you there's only 10. And Epitech is a common one that you would find out there. The originator is called Lamictal. And then there's Aspen lamotrigine and this lamotrigine, and there's a whole variety of them, Unicorn. So there's a variety of them that can be used. And they're more or less better than the Degranol that I was talking about, and they get used a lot. And then there's a bunch of newer drugs that haven't yet proven themselves in terms of the registries. And there's many out there. Keppra is proving itself. It hasn't yet come into the focus. And then there's a drug called Fycompa, which is out there now. But there's a whole variety of them. And then there's a pro-drug to Tegretol, which is also relatively safe. Old drug called Trileptal.
Yeah.
There's no generic for Trileptal, and it's also probably a safer drug. So those are the good and bad drugs. So I think we need to understand that. The other problem that we as neurologists face is that epilepsy is not one homogeneous mass.
No.
So when we look at epilepsy, we can look at epilepsy that only happens in the children that are newborns. Then we can look at epilepsy that occurs in the 0 to 4 years age group. And then we look at children with epilepsy that are under the age of 10. And then you look at epilepsy that happens under the age of 20. And then you look at adult onset epilepsies. So epilepsy is just no homogeneous mass. In addition to that, you can get epilepsy as a result of a tumor or a meningitis or a head injury. So the pathology that happens in the setting of epilepsy can be varied. And so we choose drugs based on the type of possible scenarios that the patient manifests with. And anti-epileptic wise, valproate can be used for a whole all the varieties, and you can get a benefit.
Yeah.
And we always talk about the efficacy of anti-epileptics. And in terms of epilepsy use, 70% of patients, whether you take it out of a neonatal age group or an adult age group with tumors or whatever, 70% of patients will be controlled with Epilum. 70%. No other drug has come to that level of efficacy. And that's why you can go anywhere in the world, you'll find valproate, because it's just so good as an anti-epileptic. And the others haven't even come close to giving you that level of efficacy across a spectrum.
Wow.
And that's why it's used so often.
So, Dr. Rowji, thank you for that. So I suppose what's coming to my mind now is, if we're saying that is the drug that is a neurologist's choice, and it is the one that's most freely available in South Africa, and we also know that that is causing problems in pregnancy, what can a person, a woman with epilepsy, then what are her alternates in terms of a safer drug that helps her, that she's going to have a safe pregnancy, that her seizures are going to be in control, and if she's got any other neurological disorders, that they're all taken care of? What does a woman have as an option?
So remember, that's where the folic acid comes in.
So it's critical to have folic acid.
So ideally, you want a patient to be taken off valproate and put onto something that is more pregnancy friendly. Okay. But that doesn't always happen. So then the best you can offer is that she is on folic acid, so that if, heaven forbid, she accidentally falls pregnant, you've mitigated that risk somewhat. But I mean, you can correct me if I'm wrong. I haven't delivered babies in a few years, so I haven't looked at the epilepsy in pregnancy guidelines that recently, but my understanding has always been that the drug of choice for a woman, a pregnant woman with epilepsy, is basically whatever drug she was taking before that she was stable on, as long as it's not valproic acid. Yeah?
So having said that, so there's some conditions where valproic acid is the only drug that works.
Yeah.
And a classic example is a condition called absence epilepsy.
Okay.
So absence epilepsy, the classic absence epilepsy, gives you a specific EEG change. And in that group, we find these patients are quite specifically dependent on valproate. The other one is juvenile myoclonic epilepsy. So those two are very sensitive. And in juvenile myoclonic epilepsy, we use it at very low doses over a period of time. We kind of reduce the doses to a point where it actually gets controlled. But there's still some patients, after having tried a variety of drugs, that are only going to be controlled on valproic acid. And then we would add a drug like Lamictal as a second agent. And in that particular setting, we drop the dose and concentration of the valproic acid. So we get to a point of 600 milligrams or less of the daily dose of valproate. And then we have a second agent that controls it. So that's where we would want to use polypharmacy. These are the patients that are so very needy of the valproic acid to control them. And sometimes even that doesn't control them. So the patient still has breakthrough seizures, even when they're on 2 or 3 drugs. Now you are sitting with that added problem of having polypharmacy, and that risk is being, is kind of being increased of developmental abnormalities. So it can be quite a tricky game to play. And thankfully, it's not many patients. Of the many patients I treat, I mean, I think I can put it as a clear number as a handful, and it is that, 3 or 4 patients. And in my career as a neurologist, I've not seen many developmental abnormalities, thankfully. And I pray certainly that is the case, that we don't see them, for a long time to come. But the point is that they do happen, and we have to mitigate against them, and we've got to warn patients and inform them. And that's why this series is so vital, is that we need to be advocating education, and the education of particularly of the women of childbearing age using anti-epileptics.
So our approach in obstetrics is always that you have to weigh the risks of the drug with the benefits that they provide to the mother and the fetus, but mostly the mother, with the risks of not being on the drug. So even though I say valproic acid we avoid at all costs, we cannot, as you've put, avoid it. And that's in some patients, and that's the case with many, many drugs. You have to put the mother first. Because without the mother, there will be no fetus, there will be no baby, there will be no pregnancy, there will be none of that. You have to prioritize the mother. So there will always be, unfortunately, that handful of patients that cannot be without that drug that we would really, really don't want to use. But we try and mitigate the risk, and at the end of the day, we've got to have a safe mother, and we've got to have a well-informed mother. So these issues need to be discussed with women. And yes, while we enforce that these drugs have got these risks, by the same token, they need to understand that they need the drug. They need it, because without the drug, there will be no baby, and there will be no future potentially for them.
You know, I think, listening to you, I mean, we're talking about the ideal of those 50% of women that will take counsel when they fall pregnant, that that's not the whoops environment, and then they can balance their meds and they can be on the right one and they can protect themselves and protect. And I think the greater conversation, exactly what you're saying, is there's such a balancing act with a neurological disorder like epilepsy, because there is, like you said, there is no one size fits all. It's, is the woman sleeping correctly? Is she eating correctly? Is she having enough vegetables? Is she doing exercise? Has she got a balanced life? And we look at South Africa today, and certainly all that is a concern. So, yeah, thank you for your inputs this evening. I think we've got to that stage where we've chatted to most of the questions that are coming through, and you've been particularly quiet since your beautiful presentation. Would you like to add?
I spoke so much today.
Would you like to add to comments and discussions, add further?
So when we talk about benefits versus risks, I do see quite a few patients on anti-epileptics. And unfortunately, when the mum is in that situation, she does what is quite natural that a mum would do. A lot of them just stop their medication. Yeah. It's something that, you try very hard to explain that you need it, and it's just what she thinks she's doing that's best for her baby. So in that situation, we actually faced with that situation quite often. That's what I see. And it's difficult to get them back onto it. That's the problem.
Also, Jayshree, were you not saying that a lot of the patients that you see through the fetal medicine clinic at Barra, for example, are on inappropriate drugs?
So we still very widely use Epilim, unfortunately.
Which speaks once again to the education factor of healthcare practitioners who are prescribing those drugs.
No question about that. That is a big, big issue. How many have you seen developmental abnormalities associated with our anti-epileptic use?
So what I see mostly is the neural tube defects. So the spina bifida is what we see most often. And I do tend, and I was telling Judith, that if a patient's had it, then I tend to find that she may have another child with another abnormality. So that's what we tend to see. Factor. So definitely a genetic factor. We assign a term to neural tube defects. We say it's multifactorial, because there definitely is a few factors involved in it, but genetics seems to play a role, definitely.
Thank you.
Are we seeing less cleft lip and palate?
So in my experience, having worked for 18 years, yes, I didn't see as much cleft lip and palate. Obviously, it would be nice to see with lamotrigine, it's definitely, there's a higher rate of cleft lip and palate, in fact, orofacial. And now with it being more widely used, our problem we have in South Africa is we don't have a registry, nor do we belong to one. And it would be nice to see our stats. Even this 50% of unplanned pregnancies, that's not South African stats. That's actually in the developed world, by the way, that we have.
So it might be high or it might be lower.
Our stats would be different. It would be nice to have South African stats to actually comment on.
The other issue, I think, is that a facial cleft in the hands of a good surgeon can be treated. You know, nobody wants a baby with any kind of problem, but facial clefts can be treated with surgery, whereas a neural tube defect, if you have a really bad one, can have significant consequences for that individual and for the family who has to care for that individual. So it's a big one, and that's why I think the focus has to be so much on that aspect.
Yeah.
So I think we're getting to that point where we need to do closing remarks. So can I ask you, Pradeep, you've given us so much valuable information, just your closing remarks to all the women that are of childbearing age out there with epilepsy. What is piece of guidance, that wise counsel that you can leave them with now?
So the very simple thing that I want to mention is that do not stop your anti-epileptics, especially not during your pregnancy.
Okay.
Make sure that you get folic acid as a prescription that is added to your anti-epileptic drug.
Okay.
And most importantly, work with your obstetrician and neurologist to ensure your safety through the pregnancy.
Great. Thank you, Pradeep.
So from my point of view, and that's from a maternal fetal point of view, I think it's important not to cut corners. They are high-risk patients and they should be referred for their 12-week assessment, their 20-week assessment, if necessary 16 weeks as well, and if necessary referral to a pediatric cardiologist to assess the heart. But it is something, I think the steps that are important to take in all pregnant women.
Okay.
Don't be scared of the intrauterine device.
That's it.
Loops all the way.
Okay.
Once you go loop, you never go back, most of the time.
Well, thank you. Well, I just want to say on behalf of Epilepsy South Africa and certainly Sanofi Aventis for this evening is just thank you so much for sharing your expertise with us this evening. Thank you so much for the valuable insights that you've given us. And one of the things that's just stood out for me tonight is we are advocates as Epilepsy South Africa, and we are here to teach and to teach and to teach. And I think these forums are going to prove so invaluable going forward. So what I'd like to say to everybody that's joined us, join us as Epilepsy South Africa, join the conversations, email us on info@epilepsy.org.za, and certainly reach out to us. You can become members of our organisation, you get more and more access to so many other things, and know as a person with epilepsy that there is a community out there that can give you the support, that can give you the care, and you can access information like we have this evening. So from me, thank you so much for being with us this evening. For all of you that have made comments on the chat, that have joined us this evening, thank you so much. And just remember, this is being saved on our feed. You can watch it later on. You can share it with your loved ones and further circles that could help and provide support to other women. Please share it as far and wide, and hope you have a good evening, and thank you once again for joining us.